Hey guys, today we're talking about cupping. I know if you go Google or YouTube cupping or cupping therapy, you're going to see a lot of videos. Just like anything else to talk about, I'm going to try to cut through some of the BS, bring up some of the myths, discuss what we think, as it's usually a working postulation with most things, what we think is going on based on research and some anecdotal clinical evidence, which you still have to take into account even if you're the most evidence-based practitioner in the history of the world. So, what is cupping? Cupping uses these little guys, right? They could be gals. I don't know if they're gender neutral or not. I don't know. But you see them put them on their skin. It became really hot when Michael Phelps showed up with all these bruises. Looks like he got attacked by an octopus or something. Well, cupping has been tracked back to almost 5,000 years ago. Egypt, Budapest, Jerusalem, all these places, even Native Americans in North America use buffalo horn. Most people equate it to about 3,000 years ago to Japanese. That's when the traditional wet cupping, or basically making an incision in the skin, putting a cup on that we used flame, right? So a flame inside, which some people still do this, and then put it on the skin, and we're drawing the blood out. A lot of this was based on mysticism, some things that may or may not be true, pulling toxins and maybe some spiritual aspects out of the blood, out of the body, almost bloodletting. Well, we've moved on and we use it more, or I guess a lot less, for bloodletting of any kind of crazy demons or anything like that. And now we just make crazy bruises that get a bunch of funny memes on Instagram, and then we make fun of Michael Phelps. But what we use it for in the clinic is usually pain modulation. So the first thing we have to bring up is this, the thought between dynamic versus static cupping. So the bruises on Michael Phelps, let's just bring up that extremely popular example. They left those cups on there. I don't know how long. I wasn't there at those Olympics. It was one of the only Olympics I didn't compete at. But they left those cups on there for, who knows, 5, 7, 10 minutes maybe. That's why you saw the dramatic bruising. But Michael Phelps, as most people saw, was just laying there while the cups were on him. So I don't know how beneficial this is, and there's really no evidence that looks at dynamic versus static cupping, which there should be. But when we're doing that, the thought process has been that we're basically bringing new blood to the area in tissues that may have stagnated blood due to trigger points, tight muscles, things like that. So when we look at the evidence behind cupping, this is some of the stuff that is proposed for the mechanisms of action are these: bringing new blood, eliminating stagnation. These are all extremely vague terms. Stagnation of what? Are we just talking blood, lymphatic, fluid, all these things? The thing that we have to take into account is how physiology actually works. So I've seen a couple videos by some other really famous, I'm not throwing myself in that category, just some people that have a lot of views on YouTube explaining this stuff. And some of those docs and other professionals would say that we're bringing blood to an injury that it has not healed properly or healed 100%. Well, this is not my clinical opinion. This is based on research, which in the comments section of this video, I'm going to post some research articles or some links to. That's not how the human body works. We don't wall off injuries and forget to heal them. The only things that we wall off are called abscesses or tumors. So when we have an old injury, a musculoskeletal injury, we don't just not heal that and then all of a sudden we can bring new blood to it. And sometimes this has been equated to like a plasma-rich, or a platelet-rich injection, a PRP of some sort. Well, that's not quite true either, because just because we're bringing blood to an area by bruising it, which you may equate to a hickey, doesn't mean that we're bringing all of the agents that would be in plasma. So to get a PRP injection or a platelet-rich injection, we have to spin that down in a centrifuge so the plasma is separated from the heme itself, and then we have all these healing agents in the plasma. So these cups are fantastic, but the technology behind this little plastic cup from Korea is not great enough to just target plasma and bring that to the area. So I believe that to be false. Again, there's no evidence for or against this. What there is a lot of evidence on is a lot of individual case studies, and then a lot of RCT studies where they've looked at basically benefit outcomes or just overall outcomes for things like neck pain, back pain. A lot of early cupping actually dealt with pulmonary issues and respiratory issues. So I believe the very first documented cupping therapy session ever out of Japan that was documented was for tuberculosis. A lot of people would say, and a lot of people do still use cupping for the treatment of respiratory issues, even asthma and things like that. And they're saying that we're bringing new blood to the area. We're making the circulation greater in these areas. My wife, who's behind the camera right here, Dr. Sloan, we had a talk about this, may have turned into a debate. That's what good doctors, good physicians, good husband and wife can do, is talk. But we were talking about this idea of bringing new blood or increasing circulation or hyperperfusing an area. The thing is, if you think about a bruise, that's actually stagnated blood, right? That's blood that has been basically brought to the surface, or we've had damage and there's pooling of blood. So a bruise is stagnation. So even though we may have brought blood there, I don't know that the blood's moving so well after we leave. So this idea of this hyperperfusion or bringing new blood, I don't think is great. So when we get back to thinking about respiratory issues, a lot of the times we're seeing treatment occur around the thoracic spine. Well, we know the thoracic spine is basically the area of the spine where we get a large input in the sympathetic nervous system. So we have the sympathetic ganglion that run up and down the thoracic spine. Well, if we were to administer an HVLA adjustment or mobilizations or foam rolling or cupping or perturbation or vibration, you get a big input to that sympathetic nervous system. Sympathetic nervous system basically helps open up the respiratory system, so if I need to run from a bear, I can get more oxygen. So again, this hasn't been studied specifically. These are things that should be studied, but what we need to stay away from are these false narratives of telling people that we're bringing new blood to an area, that we're opening up congestion. To me, that's the same thing as saying adjusting a subluxation or that I'm, breaking up an adhesion. Just because we think that it's happening like that and we have positive outcomes, we shouldn't be telling patients or having patients rely on, or even people that are watching a video rely on a false narrative for these things that are helping them, right? So we know that we're not reliant on the modality. We're actually still intelligently using the body's physiology to our benefit as practitioners. So we've talked about kind of where cupping came from. We talked about static cupping, sticking cups on and just kind of leaving them. We use more dynamic cupping. So we'll put a cup on. Let's put one on here real quick. So let's say I'm going to put this on this big meaty bicep. It's gigantic, at least 28 inches. I don't know. But you can see that this cup gets pulled up in there. Now, it's going to pop off. That's like a turkey thermometer. You know it's done. But let's say the cup's still on there. Now, as I move my arm with that cup on there, all of that tissue, so the skin, the superficial fascia, some of the muscle, the nerve, the veins, the arteries, are being pulled, or at least there's a negative pressure created. And now if I move against that negative pressure, well, my brain has to alter the way it's been thinking about stuff. And the other novel thing about cupping in particular is it is the exact opposite of most modalities in a clinical setting. So cross-friction therapy, instrument-assisted soft tissue, foam rolling, compression, adjustment. These are always compressive, voodoo floss. This is one of the few things besides just skin rolling that is actually a negative pressure, or we're decompressing tissue. Very rarely do we do that in clinical or just in our normal soft tissue maintenance on ourselves. So when we move under that cup, we're forcing the brain to think about that movement in a very different or novel fashion. And that's where I think, right, and this is extrapolating from other areas of research, and it wasn't me or anybody else besides really pain management doctors that came up with this whole kind of idea of working with superficial neurology. That's where you would get a trigger point injection. So when you're getting a lidocaine or benzocaine injection, we're looking for areas of superficial neurology like my friend Dr. Philip Snell and Dr. Justin Dean came up with a thing called yapping, which is very kind of a slapstick name, or yanking away pain, but it's based on the whole premise of creating movement around the superficial tissues in specific areas where we know that the neurologic structures are very superficial to the skin. And those are a lot of the times where we see this sensitization, or this basically heightened awareness in a nerve occur. And a couple of these areas in particular that a lot of people have probably dealt with pain are areas around what's called the cluneal nerves. So the cluneal nerves kind of wrap out around from the lumbar and lumbosacral nerve roots and go down around the hips and even down into the saddle region. And I tend to see in clinical practice a lot of sensitization of these nerves, in particular with extension-based back pain. All right, and this would make sense. It's almost like a preemptive back brace set up by your neurologic system, right? So if I'm having pain with extension, maybe I can get these nerves to fire up a little more, and all of a sudden I have more pain than there actually is pathology. Well, a really good way to combat that, as long as I don't think that the pathology is going to get worse if I extend somebody or get them moving better, is to put something that's a very good pain modulator on the area, like a gigantic cup, get them to move with their brain thinking about this novel thing that's stuck on their back, and all of a sudden we take the cup off, and that perceived movement, whether it was flexion, extension, whatever the movement was, has changed because we just injected a very novel, right, input to the system. Nobody walks around pulling on their skin all day or with a giant suction cup on their back. Other areas that people have more than likely dealt with before would be some superficial neurology, where we see a lot of trigger point injections occur around the suprascapular nerve, and then even areas like Erb's point, where we get three to four branches of superficial neurology that basically trace up, away, and around from the neck and jaw. So these are obviously areas that we in our society deal with pain, musculoskeletal issues day in, day out. So it's always good to think about things that may be alerting us to issues that could occur that may not be as bad as we think they are before they actually get that bad. Instead of going with the most invasive kind of treatment first and thinking, man, I may have a cervical disc issue going on, I may have a torn rotator cuff, when really it's altered mechanics, or you outpacing capacity because you're working out more than your shoulder can withstand right now, and your brain's trying to alert you through pain, which pain is just a communication between your nervous system and your body to say, hey, you need to change something. If you don't change it enough, you will get hurt. So that's where we see cupping playing a very important role, or a very different role. It's a role that is not really able to be done by too many tools in the clinical practice, or at least in manual medicine. So I hope you guys learned something in this video. Like most of my videos, I'm just trying to cut through some of the myths, some of the ideals that are out there that may or may not be true. And like I said, I'm going to put some citations below in the comments. Now realize, and this is one thing that has been pointed out about the research or the literature surrounding cupping therapy, most of the research comes out of Eastern Asia. Well, the biggest reason that is because that's where cupping is done the most. The thing wrong with that is that it's overwhelmingly positive outcomes with this research. And anytime that you see a very strong bias, you can almost guarantee that the research itself is not as great as it should be. So there should be done more stateside and anywhere else in the world. And I would say that we need to look at the mechanisms, applications, and then see if we are mimicking other treatments like trigger point injections and things like that, to see if we can maybe bleed manual medicine more into those invasive realms, so we're not getting people, again, stuck on a false narrative of thinking they need an injection. It may just be something as simple as grabbing your skin and moving it around. Hope you guys learned something. As always, question everything, find your truth. See you guys next time.